Hi, my name is Helen. The authors of this video would like to present a case of a patient with recurrent GIST who underwent a successful robotic esophagojejunostomy with double-tract reconstruction. The authors have no disclosures. 76-year-old female with a history of hypertension, chronic kidney disease, and significant vascular disease, including PAD and history of bilateral carotid stenosis on Eliquis. During initial workup for groin pain, she underwent a CAT scan that incidentally demonstrated a 5-centimeter gastric mass in the cardia that was confirmed just on EGD. She underwent 6 months of neoadjuvant imatinib and a proximal gastrectomy with a gastroesophageal anastomosis. She declined adjuvant imatinib and was lost to follow-up for about a year until she saw us at our cancer center. Her initial presenting symptoms were early satiety, significant weight loss of 20 pounds in the last several months with failure to thrive. Her performance status was ECOG 1. She was admitted for nutritional evaluation and started on TPN. She underwent a repeat CT abdomen pelvis with PO and IV contrast that demonstrated a 90% stenosis of the SMA as well as confirming the recurrent proximal gastric mass. Given her symptoms and radiographic findings, it was felt that her clinical picture was consistent with chronic mesenteric ischemia, and she underwent a visceral stent placed near the SMA ostium with adequate post-procedure flow. She had complete resolution of her intestinal angina and was discharged on dual antiplatelet therapy. A week later, she presented to an outside hospital in hemorrhagic shock from an upper GI bleed requiring MTP and an EGD. Shortly after, she had a second readmission for syncope and melena. Given her ongoing symptomatic bleeding GIST, the decision was made to plan for surgical management. The patient was brought to the operating room, placed in supine position with both arms out. The abdomen was entered at Palmer's point with a varus, and an initial diagnostic evaluation did not reveal any metastatic disease. These are the 4 8mm robotic trocars that were placed, with an air seal assist in the left lower quadrant. Dissection began at the pars flaccida by taking down the dense adhesions between the liver and the stomach. Using a combination of sharp and blunt techniques, the dissection was carried towards the hiatus of the stomach. The left gastric artery and vein were identified and divided with a vascular load stapler. The peritoneum overlaying the left and right cruce were opened circumferentially, identifying the hiatus and the GE junction. Five centimeters of esophageal length was achieved and brought down tension-free into the abdomen. The antrum of the stomach was transected with a 60mm purple load. The distal esophagus was transected in a similar fashion. From the ligament of Treitz, 50 centimeters of jejunum was measured and brought up in an anticolic fashion up to the esophageal stump in a tension-free fashion. A hand-sewn 2-layer esophagojejunostomy anastomosis was created. The posterior layer was completed using a 3-0 knotless unidirectional barbed absorbable running suture, and the anterior layer was performed using a 3-0 PDS in an interrupted fashion. The gastrojejunostomy anastomosis was created approximately 20 centimeters from the first anastomosis using a stapler with closure of the common enterotomy with a continuous barbed B-lock suture. Prior to closure of the common enterotomy, there was significant amount of remnant food bezoar, demonstrating that the patient had pyloric contraction. This was manually removed to prevent disruption to a fresh anastomosis. 30 centimeters from the GJ anastomosis, a jejunostomy was created in a similar fashion and closed using the same technique as prior. ICG was performed at the end and confirmed adequate perfusion to the conduit. Two number 19 Blake drains were placed anterior and posterior to the EJ anastomosis, and an NG tube was delivered under direct visualization. Final pathology: T3N0M0, high-grade GIST. The patient did well post-operatively. She underwent a CT esophagram that was negative for leak on post-op day 3. She was discharged on post-op day 7 on a full liquid diet. She is planned for at least 36 months of adjuvant imatinib. The authors would like to thank NYU Langone Health and the Department of Surgery as well as SAGES for the opportunity to present. Thank you.